name is Alexandros Mitropoulos. I'm working as a research fellow in Clinical Exercise Physiology at Sheffield Hallam University, and I am a member of the Lifestyle, Exercise and Nutritional Improvement Research Group. Today, I'm going to present to you the preliminary findings of a combined high-intensity interval program on pain and fatigue in people with systemic sclerosis. This was a multi-center randomized controlled trial. For this European research clinical trial, we collaborated with Karolinska Institute in Stockholm in Sweden, with the Aristotelou University of Thessaloniki in Greece, with the Luigi Vanvitelli University in Naples in Italy. We were at Sheffield Hallam University in Sheffield in the UK. We also collaborated with Leiden University in Leiden in the Netherlands, and finally with the Copenhagen University in Copenhagen in Denmark. Our project was funded by Forum in 2021, and the title of our project was Exploring the Effects of a Combined, which is both aerobic and resistance-sustaining exercise program on pain and fatigue outcomes in people with systemic sclerosis. So that was a specific call for pain and fatigue symptoms. This is the team, the project leaders from each country. Professor Makos Klonizakis from Sheffield Hallam University. I acted as the leading investigator in Sheffield, and also I tried to perform the day-to-day management across all centers. Also from Leiden University, the leading investigator was Professor Alleviate. From Karolinska and Sunderby Hospitals, Dr. Malin Mattsson. From Copenhagen University, Professor Søren Jacobsen. From the Vanvitelli University, Professor Giovanna Cuomo. And finally, from Thessaloniki, Professor Evelyn Kuivi. Obviously, there were more members taking part in this European multi-center research clinical trial. This is the study protocol that we published back in 2022. And in the new study, we will have even more members that we collaborated for this in order to happen. I would like to think about the endothelial dysfunction in systemic sclerosis prior to proceed to the study design, as it's very important. The vascular involvement in this condition is critical. To be more specific, the vascular injury in systemic sclerosis is considered an initial event in the development of systemic sclerosis, and it could be triggered by the autoantibodies, which are just above the immune cells, or infectious agents, another trigger point. It could be also triggered by reactive oxygen species, or idiopathic stimuli injury. In the early stages of systemic sclerosis, the vascular damage leads to activation of endothelial cells, expression of adhesion molecules, the production of chemokines, as well as the production of von Willebrand factor, and the production of vasoconstrictor agents such as the ET1. At the same time, we can observe a reduction in the production of nitric oxide and endothelial nitric oxide synthase, which are natural vasodilators. So by having an increase in the vasoconstrictor agents and a decreased reduction in the vasodilators, we then lead the whole vasculature to a vascular tone imbalance, and this imbalance leads to tissue hypoxia, intimal hyperplasia, luminal narrowing, and vessel obliteration. So all these abnormalities, the vascular abnormalities, are strongly correlated and linked to clinical manifestations, which have got as a basis the vasculopathy. And these clinical manifestations are Raynaud's phenomenon, pulmonary arterial hypertension, scleroderma, renal crisis, and digital ulcers. And all of those manifestations severely affect the quality of life for this population and also may compromise their survival. So, what exercise can do to improve this vascular imbalance? Exercise has found in other clinical conditions, and this is very well known so far, that it can increase production of nitric oxide and nitric oxide bioavailability, and this is an acute effect of exercise. It can also alter the arterial structure by increasing the arterial caliber and wall-to lumen ratios. This is a long-term effect of exercise, and when we say long-term, for this specific effect, we usually say around 3 months, although 3 months, someone could argue it's not a long-term effect, but specifically for this alteration, 3 months and above has been found to be the time points. For these two alterations, the vascular function and the vascular structure, the triggering point is the hemodynamic stimulation as a result of exercise. So the more we do exercise, the more blood volume we circulate in our body, and then the blood volume pressure in the walls, which is called shear stress, is the result of increasing and excreting more nitric oxide. So the fatigue and pain are very interrelated. And the most debilitating symptoms in systemic sclerosis as well. Fatigue has got a prevalence of 50 to 90% in this condition. Fatigue and pain prevalence have got a reciprocal relationship, and they are interrelated with a prevalence of 75 to 93% for pain. Also, fatigue can severely and pain affect quality of life, and also depression can affect fatigue, and all these three can be also be affected. So fatigue could be affected by increased pain and by increased depression as well. So the aim of our study was to investigate the effects of exercise on pain and fatigue in people with systemic sclerosis. To succeed this, first of all, I would like to talk about the eligibility criteria, and then I will go to the study design. So for the inclusion criteria, we included everyone who had an official diagnosis of systemic sclerosis. They were adults, and they were able to perform the prescribed exercise program. For the exclusion criteria, we excluded those with active disease-related exacerbations, such as active digital ulcers. We also excluded those with a change of medical vascular-related treatment, such as vasodilators within the last 3 months, because we performed a vascular assessment. So we didn't want the medical treatment to affect this assessment. And also we excluded those with advanced and severe pulmonary involvements or New York Heart Association classes 3 or 4. Also, we excluded those with being unable to exercise or with current pregnancy.
So all patients were screened for eligibility. They gave their consent to participate in the study, and they ended up in 1 or 2 groups. A, those who received exercise and usual care, and those who received usual care only. Assessments took place at enrollment and after 3 months of intervention and after 6 months.
So in a bit I will play the video. So this is the peak oxygen uptake test. For this test, you will see soon in the video, the first screen will be the breathing analyzer. Then you will see a second screen, which is the ECG monitor, where we well, monitoring the ECG signs during the arm cranking. And yes, I will play now the video to see our participants. So first monitor is breathing analyzer, ECG during the peak oxygen uptake test. And here is the participants. You cannot see at the moment, but in front of her, she's got a mouthpiece, which through the mouthpiece we collect the breathing variables. This is an oxygen uptake test where it's incremental, which means that we start with a very light load, and every minute we increase the watts, the load, until the participant cannot continue or until we might find some abnormalities in the ECG. I will play one more time the video, and then I will continue for the next slide. One more time. This is in the early stages, as you can see, with only 82 beats per minute. And the ECG patches are attached. So we are proceeding to the next slide. In this slide, it's our protocol. In total, it was 30 minutes of high-intensity interval training. And in these 30 minutes, we were going at 30 seconds, 100% of peak power output, which we could find through the peak oxygen uptake test that you just saw, and 30 seconds passive recovery for 30 minutes. So the actual exercising time was 15 minutes. That, again, was taking place twice per week for 3 months, and it was always supervised. So why did we select the high-intensity interval training protocol? Because there was a paper of systematic review back in 2015 that examined the impact of high-intensity interval training versus moderate-intensity continuous training on vascular function. And they found that HIIT is more effective at improving the brachial artery vascular function than moderate intensity continuous training. Another more recent systematic review assessed the impact of high intensity interval training on vascular function in adults, and they found that HIIT is effective for improving vascular function, and that is superior, has a superior effect compared to moderate intensity continuous training. So that was the evidence and literature review that was performed prior to use the high intensity. As it concerns the resistance training part, so the aerobic was 30 minutes, and then we utilized around 15 minutes of upper body resistance training. We performed 3 cycles of 10 repetitions maximum of the following 5 exercises that you can see in a circuit mode. So we're performing the chest press, and then following a short duration of time, 10-15 seconds until we change the exercise, we're going to the next exercise. There was like a short break after the 5th exercise, and then we were repeating 2 more times. The demographics in our study were that we first of all recruited 170 participants across all 6 centers. We had 10 dropouts, 5 in the exercise and 5 in the control group, which totals to 6% in overall. We did a group randomization based on disease severity, duration, and gender in order to have balanced exercise and control groups. The exercise group had 86 participants, and the control group had 84 participants. The mean age of our participants was 59 years old. The mean disease duration around 11 years. We had 83% of our participants being women, as this is the prevalence of this condition. And most of our participants, 87%, presented with limited systemic sclerosis, and the remaining with diffuse systemic sclerosis. Going to the body composition analysis results, at baseline, we didn't observe any significant differences between the groups in fat mass, but also in the other body composition analysis outcomes, such as the muscle mass. However, as you can see, at 3 months, we found a significant difference between the exercise and control group, with the exercise group presenting significantly less percentage of fat mass compared to the control group. This difference was not maintained at 6 months. However, as you can see, it was very close to being significant, which is important, and we will see other outcomes that although the participants stopped the exercise following the 3 months, some of the outcomes were still maintained, not all of them. So, for the visual analog scale questionnaires, we asked about pain, breathing, Reynolds phenomenon, pain and involvement of Reynolds phenomenon in breathing, and overall limitation of the condition. At baseline between the groups, we didn't find any significant differences. However, we did find significant differences at 3 months, and for all of these outcomes, the exercise presented improvements. Overall, pain and Reynolds phenomenon are linked to microvascular involvement, ischemia, and inflammation in systemic sclerosis. And exercise has demonstrated in our previous studies that it's able to improve the microvasculature and reduce the pain which is induced by Reynolds phenomenon. So it is also possible that exercise in systemic sclerosis can improve the tissue oxygenation and down-regulate the inflammatory responses, further adding to the overall improvement that you can see in pain. As with respect to the fatigue, quality of life, and depression and depressive symptoms, I will present you straight the results of the 3 months. At baseline, we didn't have any differences between the groups. So at 3 months, we can see that the overall fatigue was much better for the exercise. Quality of life and depressive symptoms significantly better for the exercise group. As we said previously, fatigue is strongly correlated with depression and pain. So improvements in depression and pain, as well as improvement in social activities. This is a result from previous studies, but this is correlated as well, may justify the improvement in the fatigue. For the fatigue and the pain, I didn't mention that before, we didn't have any maintenance of the significant differences at 6 months. So for the Scleroderma Health Assessment Questionnaire, because there are a lot of questions within this questionnaire, I have highlighted those questions which in our results were significantly better for the exercise group. I will not go through all of them, but you can see that some of them are very closely linked to an improvement in musculoskeletal strength and functioning and cardiorespiratory fitness. So we do need some strength and functionality, physical functionality, to stand up from an armrest straight chair. So this is under the arising. We do need some physical functioning to get in and out of bed. We do need some strength in our upper body, hands and arms to cut a meat. And also we do need some cardiorespiratory fitness to climb up 5 stairs. Here there are other highlighted questions. So only the highlighted present significant differences. Those that they are not highlighted did not present significant differences. In this page, we could see that if we go to the reach, we were asking the participants, are you able to reach and get down a 2.5 kilo object, such as a pack of sugar, from just over your head? So by having this significant difference for the exercise group, it shows that the exercise group improved the functionality and musculoskeletal strength in the upper body, and thus they were much better to perform this type of activities compared to the control group. So what we just observed before in the previous questionnaire about having improved physical functioning and musculoskeletal and cardiorespiratory fitness, it is evident through statistics and through our tests. So we can see at 3 months no difference at baseline and no differences at 6 months. So at 3 months between the groups, the exercise group was much better in the hand grip strength test of the left arm. This is a strength test. They were much better in the biceps curl, which is an endurance upper body test. This is a test where they perform for 30 seconds biceps curl with a dumbbell, 2 kilos for women and 4 kilos for men. Oxygen uptake was significantly better for the exercise group compared to the control. This is an indication of the cardiorespiratory fitness, as well as heart rate was significantly better, and the peak power output during the test was significantly better as well. So our exercise program can improve disease-specific quality of life. It can also improve depression. It can also reduce pain and fatigue caused by systemic sclerosis. It can improve cardiorespiratory fitness, muscular strength, and endurance. And finally, it can reduce body fat. Some of the future implications following our findings would be to examine more. First of all, we have to analyze more data of our assessments. As I said, we have performed nail follicular capillaroscopy, which is going to be assessed. And locally, in the UK, we have performed some bloods, and we will assess related blood biomarkers and endothelial cells pre and post exercise to see and observe any differences. Now that we know that this exercise program works and this intensity, we would like to assess in the future the feasibility of a pragmatic exercise program as part of a country's healthcare system. So we would like to proceed to the implementation phase after this definitive trial that we performed and try and implement this as a non-pharmacological intervention and treatment for this condition in each country's healthcare system. As part of this implementation phase, we would also like to explore the barriers to exercise referrals by clinicians. We would also like to assess the cost effectiveness of such a pragmatic exercise program and if it can be implemented wider within a country's healthcare system. And we would also like to explore the barriers to long-term adherence to exercise programs. As we know, and as it was evident in our results, as soon as we stop exercising, we lose all the benefits from the exercise. So the long-term adherence to an exercise program should be one of the basic aims for the future. To succeed this, potentially we need to include within an exercise program education and behavioral change support, and this is something that we need to explore in the future. It will follow now a video from our participants, 3 of our participants, that they share their experiences by participating in our exercise intervention in Sheffield in the UK, and this is very, very interesting to watch. Thank you very much.
I'm Janice. I live in Sheffield and I've been diagnosed with systemic sclerosis for the last 6 years. I was always feeling tired. I couldn't explain it to anybody, just like a balloon, and the balloon just goes. Now I'm very different. Since I've got on the medication and I've been doing some exercise, it's helped me immensely. I've been able to walk more. I'm doing maybe a couple of miles walking a day. I'm doing heavy housework. I'm making the beds myself, and I don't get help. I do it all on my own. To get back home after the first day, it took me an hour and a half to get home. I was really, shuffling. I thought I'd keep stopping. I thought, this is madness what I'm doing. And then the following time I went and came back and walked it. Didn't take us long. Great. And then I realised I was running down here. I really enjoyed it. After the 3 months, I still continue to exercise the best way I can. It's helped me to socialise now. I can get back to doing what I used to do.
Like that?
Dancing, line dancing, yes.
My name is John. I live in Sheffield, UK, and I was diagnosed with systemic sclerosis less than 2 years ago. I volunteered for your study and straight away enjoyed it. I enjoyed the routine of having to come to Sheffield Hallam University twice a week. It gave me a discipline for regular exercise. So I do a daily exercise with weights now, which I never did before. And I've also joined a gym, and I do swimming, which I really enjoy. But prior to this exercise regime, I would never have considered joining a gym. That was something I didn't think that I would be interested in. Well, the first thing I did was I bought myself some dumbbells, so I could replicate the exercises that you'd shown me. So I tried to do those every day, and if I miss a day, there's a feeling of letting myself down. So I'm definitely into a regime, and try to get to the gym twice a week. I make the time now, and I wouldn't have done before. If you just sent me a list of exercises and a set of dumbbells, they probably would have just stayed pretty much unused. But having the one-to-one tuition, it's given me sort of a confidence to replicate them myself. So I can walk into that gym, not feel self-conscious, not feel as though I shouldn't be there. So it's just become a natural thing to do now. I would recommend exercise to everybody, and particularly to try it if they have systemic sclerosis. I can appreciate that for some people that could be quite unpleasant, but for them to certainly give it a try, and they might or hopefully will feel benefits from it.
My name's Sarah, I live in Sheffield and I've had systemic sclerosis for about 25 years. I don't think I really experience pain and fatigue a great deal. I think I have fairly minor symptoms, but I certainly, due to typical Raynaud's, I turn blue quite a lot, but I don't get pain with it, and I don't think I suffer fatigue. My experience of the exercise intervention was quite positive. I quite like to exercise anyway, and it was a motivation for me to do a bit more, and it was good to do something a little bit different. I can't say I particularly enjoyed hand cycling. I know some of the machines were broken at some of the time when I did rowing, and I found that better, but I did persevere and do hand cycling. I found the hand cycling to be a little bit of a waste of my time, because I only exercised my arms, whereas rowing I could do both my arms and legs at the same time, so it was more efficient for me. Yes, I quite enjoyed the weights. I'm quite feeble, but yeah, I found it a good challenge, and I quite enjoyed doing that, and I think I did get a little bit stronger, but it's not my natural place. But yes, I did enjoy it, yeah. I think I prefer the interval training protocol. I'm the kind of person that will probably go for that more than if it's a long duration type approach. I'd be inclined to stop and have a bit of a rest. If I did experience any side effects from the training, I think it was positive. I think I got a bit fitter. I don't think I experienced any negatives. I can't say I noticed it making any difference to my hands going blue. But yeah, I enjoyed there was a positive experience for me. There's obviously physical benefits beyond just helping with the condition, but I think it just makes you feel better generally. So, those endorphin rushes or whatever they are, they just make you feel better, get out in the fresh air. If you can, in the gym, whatever, I just find it a positive experience.
I'd like to thank you personally for inviting me to do it. I've certainly got a lot out of it, and it's made me look after my body more, and not just exercise by doing walk, but to actually have a daily routine, which if I don't adhere to it, I feel as though I've let myself down. So I'd like to thank you.
I would really recommend exercise to everybody. It's helped me and it will help you.